Welcome to the deep dive. Today, we're really getting into it, taking a close look at pregnancy. And look, this isn't just about spitting out facts. Our mission here is to kind of peel back the layers of clinical information, translate that complex medical stuff into knowledge that's clear, that you can actually use. Basically, give you a shortcut to being genuinely well-informed without, feeling totally swamped.
Yeah, exactly. And we're doing that by drawing straight from a pretty robust clinical guide, which gives us this great medical perspective on pregnancy. We're focusing on the signs, the key screenings, and the really vital safety points that matter.
Okay, so get ready. We're going to uncover some maybe surprising distinctions, get into crucial info that could really empower you and basically arm you with practical knowledge you'll want to hang on to.
Yeah.
From understanding those very first hints of pregnancy, navigating the essential screenings, all the way through ensuring safety throughout the whole journey, we've got a lot to cover. Let's dive in. So let's start with what seems simple, but maybe isn't always. How do we really know someone's pregnant? You'd think, oh, it's obvious, right? But medically, there's actually a progression, a level of certainty.
That's a great place to start because, yeah, the medical world actually breaks down pregnancy signs into three levels. You've got presumptive, probable, and positive signs. So presumptive signs, these are the subjective things. Symptoms, the patient herself notices and reports, things that suggest pregnancy, maybe, but could easily be something else like missing a period, amenorrhea,
Okay.
or breast tenderness, nausea, things the person feels, personal experiences.
Right, so those are the, I think I might be pregnant kind of feelings, subjective.
Hmm.
Okay. What's the next step up? What does a doctor or nurse see?
Exactly. Next up is probable signs. Now, these are things a clinician observes that strongly point toward pregnancy, but, and this is key, they're still not quite 100% definitive proof on their own. We actually have a handy mnemonic for some of these HCG. But wait, it's not the hormone test itself we mean here.
Okay.
It stands for Hagar sign. That's a softening of the lower part of the uterus. Chadwick sign, a kind of bluish color of the cervix because of more blood flow. And Goodell sign, which is a softening of the cervix itself. Now, here's the part that often surprises people. Even a positive HCG test, the actual hormone test, blood or urine even, that falls under probable, not positive.
Wait, really? The pregnancy test, the one everyone, relies on, that's not considered positive proof? Why not? That seems like it should be definitive.
It's a really crucial distinction, actually. Think of it like a smoke detector, right? It tells you there's smoke, a super strong sign of fire.
Yeah.
But it doesn't tell you for sure if it's a huge fire or just, burnt toast. You need to actually see the flames to be certain. It's similar here. A positive HCG is a powerful indicator, no doubt, but it could technically be caused by something other than a viable pregnancy in the uterus, like an ectopic pregnancy, where the egg implants somewhere else, usually the fallopian tube, or even a molar pregnancy, which is a rare issue.
Wow. Okay. I never knew that. That makes sense why it's only probable then.
Exactly. It's probable, highly likely, but not absolute until you get to the undeniable proofs, the positive signs. And for those, another mnemonic, PUF. This one's pretty straightforward. Palpation of the fetus, where a clinician can actually feel the baby. Ultrasound visualization, seeing the fetus directly on screen. And fetal heart tones, hearing that heartbeat, obtained by a clinician. Those are the confirmations. That's it. Yes, absolutely 100% pregnant evidence.
That distinction, probable versus positive, is just incredibly important, isn't it? Especially when you think about early issues that could be missed otherwise. And speaking of critical situations early on, let's talk about one that really highlights why getting that diagnosis right and understanding these signs is so vital for safety.
Absolutely. A really serious early condition is an ectopic pregnancy. As I mentioned, that's when the fertilized egg implants outside the uterus. Most often, it's in a fallopian tube. And a common reason is the tube itself might be misshapen.
Okay. Are there risk factors people should be aware of?
Yes, definitely. Things like a history of PID, pelvic inflammatory disease, or STIs, endometriosis, or if someone's unfortunately had an ectopic pregnancy before. The real danger is if it ruptures. That's a true emergency. You might see signs like a Cullen sign that's bruising around the belly button, or a Gray Turner sign bruising on the flank, the side. Both of those signal internal bleeding, which is very serious. A ruptured ectopic needs immediate surgery.
Wow. Yeah, that definitely underscores why those early precise assessments are literally life-saving.
Okay.
So shifting from an emergency like that to something more routine, but still really significant during pregnancy checks, let's talk about fundal height. It comes up a lot.
It does, and it's a simple but very useful measurement. Basically, it's the distance from the top of the pubic bone, the symphysis pubis, up to the top of the uterus, which is called the fundus.
Mhm.
There are a couple of key milestones we look for. Around 12 weeks of gestation, the fundus should be right about at the level of that pubic bone, maybe just slightly above.
Okay.
Then a bit later, at 20 weeks gestation, the top of the fundus should be right at the level of the umbilicus, the belly button.
Right at the belly button at 20 weeks.
Got it? And after 20 weeks, there's a general rule that helps track growth pretty well. The fundal height measured in centimeters should roughly match the number of weeks of gestation. There's a normal variation, of course, usually plus or minus about 2 centimeters. So for example, at say 20 weeks, a normal measurement would be anywhere from 18 to 22 centimeters. It gives a good quick check on growth.
That's a great example of how something so seemingly basic can tell a provider so much. And speaking of tracking things, let's move into that period of regular screenings. These tests are so important, designed to protect the health of both the pregnant person and the baby, right? Catching things early.
Precisely. These screenings are crucial. Let's talk through some of the main ones. First off, there's AFP, which stands for alpha-fetoprotein. It's a protein made by the fetal liver. And we typically check the levels in the pregnant person's blood between 15 and 20 weeks gestation.
And what does that test tell us?
Well, high levels of AFP might indicate a neural tube defect, like spina bifida. This really highlights why taking folic acid is so important, especially before conception and in early pregnancy, because that neural tube closes incredibly early, like 4 to 6 weeks, often before someone even realizes they're pregnant.
Wow, that early?
Yeah. Also, high AFP can just be due to having multiples, like twins. Now, on the other hand, if the AFP level is low, that might raise suspicion for something like Down syndrome, trisomy 21. It would usually lead to more testing options.
Okay, so AFP is a really key early marker. What other screenings happen as the pregnancy moves along?
Yeah, a few more really important ones. We screen for gestational diabetes usually around 24 to 28 weeks. That
Yeah.
typically involves a glucose tolerance test.
Right, the sugary drink test.
That's the one. Then later on, usually between 36 and 38 weeks, we screen for group B strep, or GBS. That's done with a simple vaginal rectal swab. If the test is positive, the standard practice is to give IV penicillin during labor to prevent the baby from getting the infection.
Okay, and what about RH factor, ROJAM?
Right, ROJAM. This is specifically for Rh-negative mothers. They usually get an injection around week 28 of pregnancy. Then, after the baby is born, if the baby is found to be Rh positive, the mother gets another ROJAM shot within 72 hours postpartum. The whole point is to prevent the mother's body from developing antibodies against Rh-positive blood, which could cause problems in future pregnancies.
Got it. That makes sense. And quickly, what about vaccines during pregnancy? That comes up a lot, too.
Good question. The main thing to know is that live vaccines are generally contraindicated, meaning avoided during pregnancy. So vaccines like the one for chickenpox, varicella, or the MMR, which includes rubella. If someone needs those, say a rubella booster, they should get it after the baby is born, postpartum.
Okay, clear guidance there. It really is a detailed roadmap for staying healthy. Let's shift now to talk about medication safety, and then tackle a couple of common complications that, understandably, cause anxiety for expecting parents.
Definitely. Let's start with something really common. UTIs, urinary tract infections during pregnancy. And here's a super important point. Even if a UTI doesn't cause symptoms, what we call asymptomatic bacteriuria, it must be treated in pregnancy, always.
Always. Even with no symptoms. Why is that?
Because there's a much higher risk during pregnancy that an untreated UTI, even a silent one, can travel up to the kidneys and cause pyelonephritis, a serious kidney infection. And that, in turn, increases the risk for problems like preterm labor. So we treat it proactively.
Okay, that makes sense. What antibiotics are generally considered safe?
Generally, penicillins, like amoxicillin, are safe, cephalosporins too. Others, like macrobid, that's nitrofurantoin, Bactrim, can be used. But sometimes we try to avoid them in the very first trimester, or imacrobid sometimes right at the very end of the third trimester due to some rare potential issues. But the ones to absolutely avoid, that includes tetracyclines and a class called fluoroquinolones, like ciprofloxacin. There's actually a teacher's tip from the guide on this. Do not prescribe ciprofloxacin during pregnancy. It's a clear no-go.
That's a very direct warning. Good to know. Okay, now let's tackle two conditions that sound similar, but are very different, and the distinction is critical: placental abruption and placenta previa.
Yes, vital distinction. Let's break them down. Placental abruption is generally the more serious, more urgent one. This is when the placenta actually starts to separate from the wall of the uterus before delivery. It causes painful bleeding, usually dark red, and sometimes the bleeding is mostly internal, so you might not see much externally. The uterus itself often feels very hard, very firm or rigid. Abruption typically happens later in pregnancy, like the third trimester, and it's an emergency. It can be dangerous for both the mother and the baby.
An emergency requiring a C-section usually.
Often, yes, an emergency C-section is needed, though depending on how severe it is and how far along the pregnancy is, vaginal delivery might technically be possible sometimes, but it's a very critical situation.
Okay, painful bleeding, hard uterus, emergency, that's abruption. How does placenta previa differ?
Placenta previa is different. It happens when the placenta is positioned low in the uterus, covering the cervix, the opening, either completely or just partially. The classic sign here is painless vaginal bleeding, often bright red, and usually lighter than with abruption. Management involves complete pelvic rest, so no intercourse, no vaginal exams. If it's found early on in ultrasound, sometimes it resolves on its own as the uterus grows bigger and kind of pulls the placenta up away from the cervix.
Interesting.
Yeah, but if it persists, if the placenta is still covering the cervix closer to the due date, then a planned C-section is necessary to avoid hemorrhage during labor.
So the easy way to remember, another really helpful teacher's tip, painful bleeding abruption, painless bleeding on previa.
Painful abruption, painless previa, got it. That's incredibly clear and useful. Okay, shifting to after delivery. A common issue can be mastitis. Let's cover that. Right, mastitis. It's basically an infection of the breast tissue. The most common bacteria causing it is usually Staphylococcus aureus, or staph. The first-line antibiotic treatment is typically dicloxacillin. It's a type of penicillin, and importantly, it's safe to use while breastfeeding.
Good to know. What if someone's allergic to penicillin?
Then alternatives like clindamycin or cephalexin, brand name Keflex, can be used. They're generally safe for breastfeeding too. And here's a really crucial piece of advice. You can, and generally should, continue breastfeeding even if you have mastitis. In fact, emptying the breast regularly helps recovery. Don't stop breastfeeding unless specifically advised by your doctor for some unusual reason.
That's often misunderstood, isn't it? People think they have to stop.
Very often, yes. But continuing is usually best. One more point, though. If the symptoms don't get better after taking antibiotics, it's really important to follow up. Get reevaluated, maybe even need a mammogram or a GYN visit, just to rule out anything more serious like rarely inflammatory breast cancer.
Okay, important follow-up advice there. Lastly, let's just touch on something that's changed recently. How medications are labeled for safety during pregnancy. The old letter system is gone.
Yes, exactly. This is a really positive change, I think, for providing clearer information. The FDA got rid of the old A, B, C, D, X pregnancy categories. They were often confusing or misinterpreted. Now, there's a newer labeling system. It provides more detailed narrative information about the risks, if any, for use during pregnancy, during lactation or breastfeeding, and even potential effects on reproductive health for males and females. It aims to give a much more nuanced picture to help providers and patients make informed decisions together.
So more detail, less confusing letters.
Pretty much. That said, some medications are still known to be absolutely contraindicated, definitely unsafe in pregnancy. Things like ACE inhibitors for blood pressure or the acne medication Accutane, isotretinoin. The key is always open communication with your healthcare provider about any medication if you are pregnant or planning to be.
We have covered so much ground here. Really a comprehensive journey through pregnancy. From those first signs, critical checks, safety nets, it feels like a genuine shortcut to being really well informed without having to wade through dense medical texts.
Absolutely. And if I had to boil down the key takeaways for you, our listener, it's really about understanding those different types of pregnancy signs, presumptive, probable, positive, and why knowing the difference matters. Remembering that crucial distinction, painful bleeding for abruption, painless for previa, recognizing why even asymptomatic UTIs must be treated in pregnancy, and of course being aware of those fundamental medication safety rules like avoiding Cipro.
It's incredibly empowering knowledge, which leads to a final thought for you to maybe ponder. Given how much our medical understanding of pregnancy has evolved, and how much detail and nuance we've uncovered just now, what other areas of your own health might benefit from this kind of deeper, more informed exploration? And how does having this kind of knowledge actually change how you approach your own healthcare journey, maybe making you a more active participant? Something to think about. Thank you so much for joining us on this deep dive today. Keep asking questions, keep exploring,